Hi everyone, I'm Tom Bardsley. I'm a senior analyst manager in the mental health team, mental health analytical team within NHS England. And I've been working in the sort of national mental health analysis with the MHSDS, among other things, for about 8 or 9 years now. So I've used it quite a lot, mostly focused on doing internal analysis, using the data to support kind of commissioners and policy leads. I think Joe said that it's a really, really complex data set. It's very massive, 60 tables, and there's an awful lot of some of it quite useful guidance, things like the data model, the user guidance, which gives you very detailed, the technical output specification as well, which gives you a very detailed description of what the data set looks like, the structure, the sort of data items and fields and services that are covered. But I'm very aware that there's also lots and lots of things in there that aren't necessarily written down, or things that are good to know if you're trying to use MHSDS. I'm happy to answer any questions and give you my best attempt at answering some of the trickier ones.
Thanks a lot, Tom. So looking through the list of questions we've received, and the main bulk of them are concerned with the referral data. So let's start with the referrals. So to start, the opening question would be, what exactly does a record represent in the referral data set? Does it mean a open referral, or does it mean those would it be repeated over years if they have multiple referrals over time?
So a referral, everything in the MHSDS has to have a referral. The entire thing is referral based, including all what we call outpatients, communities and inpatients. So hospital spells all have an associated referral. Formally, a referral is just a request for care for a particular person in a particular service. Each referral, or called unique service request identifier, has its own ID within the data set. However, a referral can and will have multiple records in the MHSDS. So in the version that I work with live monthly version of the MHSDS. So submitting organisations submit activity to the dataset each month, and although I think if you're working with some of the DARS extracts, there's some kind of consolidation there. So often there's like a financial year consolidation one. So basically, each month, organisations submit referral records for all referrals that are active at some point in the month. So that means either they were received in the month, or they were received in an earlier month and still open. That person was still in contact, or rather waiting, or perhaps even waiting for contact with the service, or the person was in contact with the service at the start of the month and then discharged in the month. So if someone is referred, say, to a service in January and then discharged in April, in the full monthly version, they will have 4 referral records, one for each of the months, hopefully, all of them with the same referral request received date, often not. And then the 4th record submitted in April will have a service discharge date completed. And so that's how it works. If you're using like a consolidated financial year one, in this example, it would span 2 financial years. So there would be 2 referral records, perhaps one from March, I think, the latest one, and then another one with a discharge date in April. That's how it works.
Thanks a lot, Tom. I think a very relevant question regarding this is the observed seasonality or increased in records that was reported before and right after April.
Yeah.
People are curious whether this is a well-known phenomenon in provision or the reporting of mental health care.
It is fairly well known. It's very difficult. So I think I should add as well, this pattern, this pattern of submitting records in every single month they happen, affects certain parts of the data set. So most notably is the referrals. It also applies to hospital spell records, to ward stays, to mental health act episode periods, maybe a few other things as well. And it contrasts with some of the other types of data that we get, which are care contacts, where there's just 1 row per event or 1 row per care activity or something like that. But anyway, on to the bit. Yeah, so the bump in, or the massive differences in data. So we know that often most NHS organisations tend to operate on a financial year basis, as that's how their contracts are administered and monitored. And it's not uncommon as well for some services to see a big swing in activity, particularly across March and April, where they perhaps might go do a bit of spring cleaning at the end of March, at the end of the financial year, close off loads and loads of these open referrals that are inactive, that are just sort of inflated caseloads, and then have a much slimmed down caseload going into the new financial year. Yeah, and so that's often down to provide. So when you see these big swings, it's usually down to provider behaviour and how they are tidying up their activity.
Well, on a related note, then, how reliable would the date of discharge of these referrals be in the referral data set, and can we use that effectively for analysis, or whether there are some known processes that you're aware of to sort of adjust for these service level variations?
It is reliable to an extent. I mean, we use it. We use the service discharge date. In general, any parts of the data set which are date stamps like that are more reliable. It's when you get into things like the precise codes around interventions and diagnosis and things like that, and outcome measurement, that's when you get to more kind of ropey parts of the data set. But date timestamps, well, timestamps to a lesser extent, but date stamps certainly are more reliable because they're easy to extract from local information electronic patient record systems. Pretty much, and so one of the big themes of understanding MHSTS and the variability in data quality is variation in the system suppliers that different NHS providers, mental health providers use. And a lot of where you find that why isn't this item, this table here completed for these people and this provider, it often comes down to that provider just doesn't have the right local technology to capture that information and submit it to a massive, very, very broad data set. However, the date that something happens, the date that someone is referred or discharged or a care contact happens is pretty good. All system suppliers, apart from maybe those small independent sector providers that are doing things on pen and paper or in Access. But anyway, they can all get a date. So they're, in general, dates are good. But we do know there are difficulties in some organisations in getting precise referral receive dates and service discharge dates. So I know you asked about the discharge date, but I might as well do both because they're quite important. The referral request receive date is, as it suggests, is meant to be the date that a referral was received by the organisation. That can vary sometimes. It may be for some services like flagged automatically when the referral comes onto their trust information system. Others might do it based on when the referral was sent from primary care or elsewhere, and there might be a bit of a difference, particularly over a bank holiday over a weekend with those things. But generally referral request is pretty good, but we do know there are challenges with that. Service discharge date has similar kinds of issues. So what you will often see when you're looking at the monthly record level referral data is first referral received in January, open in February, March, discharged in April. Then that record is submitted again in May with a different discharge date, also in May. That can be for several reasons. One, that the discharge date was just incorrectly inputted in the preceding month. It might be actually that some trusts will do it based on like the estimated or anticipated discharge date and populate it ahead of time, particularly when it's near the end of the month, because it saves them time. They have to submit an awful lot of data to NHS England with a very, very tight turnaround, and we're trying to make it tighter. So they will do anything they can to improve that. And if that means slightly, not fudging, but going, oh, we anticipate the person is planned to be discharged on this date, they'll put that in. But then something might happen. That person might deteriorate or need to be maintained longer, in which case in the next month you put in a revised discharge date. The other final thing as well is that you'll see, particularly with referral closures and discharge dates, is a referral might be received in January, submitted a record in January, another record submitted in February, another one submitted in March, and another record submitted in April with no discharge date, and then the record is not submitted again in May, June, July, or ever the rest of the year. So what's happened to that person? What we tend to say in our analysis is that if you see a referral record that suddenly stops being submitted with no discharge date, we don't just assume that the person is on caseload in perpetuity. We usually take the end of the latest reporting period that referral record was submitted in and use that as a kind of proxy inactivity date. So we'd say, So referrals can be discharged, but some referrals, often quite a few, might never get a discharge date, but they go inactive from a certain period. And I think there's a derivation in some versions of the MHSTS, which is like the inactive timestamp, or the record start or record end date, depending on what flavour of MHSTS you're using. But that is not necessarily a recommended way of recording activity, but it's common enough that we in our like official statistics use inactive referrals and use that method to add a kind of proxy discharge date.
Right. So in response to the question in the comments,
Yeah,
then
sorry.
that would be sort of the closest match to what it's like in the APC data.
Yeah, that sounds like it would be. Yeah.
Okay. So just a few more on referrals. So this is concerning the reliability of rejected referrals. And this is from engagement with local services, and they're saying some services simply don't flow rejections, they'll report rejections into MHSTS. And if they do, or if they don't, how would that be recorded or reflected? Or whether the simple use of referral rejection reason is sufficient to flag identifier of those.
Yeah, this is another one where I don't think there's going to be a very satisfactory answer to this question, because in theory all providers should be submitting all referrals regardless of whether they're accepted or not, and that includes rejected referrals. But we know absolutely that some services won't flow rejected referrals, though some services may not even have the ability to capture rejected referrals depending on how that rejection was made. So yeah, we tend to talk about we use the referral rejection date, I think, as that's slightly more reliable than referral rejection reason, as there's only a very limited number of referral rejection reasons required in the data set. But ultimately, it's one of the many things. It's hard to quantify how complete or how the reliability or unreliability of the data that we don't have.
Thanks. So the next two questions are very similar. It's concerning whether it's correct that the same person can have multiple referrals under different referral IDs with the same reason, or say suspected autism.
Yes, absolutely. Yeah, that's expected often when the same provider. So that might be two referral. So people, just to be clear, people can and do have multiple referrals open at the same time, either simultaneously, so where multiple services within a provider are seeing someone at the same time, or different organizations are seeing the same person. So, for example, some people might be on the caseload of a community mental health team provided by the local NHS trust, but then also at the same time be receiving some bespoke employment support from an independent individual placement support IPS support service delivered by a local authority or a VCSE organisation. You'd have two referrals at the same time, maybe with the same reason. You can also have multiple referrals going sequentially. So, for example, a child referred with a suspected reason of autism might have an initial referral made to a single point of access service or to an education-based mental health support team. There, they may be then an onward referral made or a second referral made also with suspected autism to the local CAMS team, and then they might again make another referral for that person overlapping also with suspected autism to a specialist autism assessment service. So yeah, it's people will appear in multiple places at the same time. What makes it particularly challenging with the MHSTS is that all services are configured slightly differently. So that example I just gave, where a single pathway, a single movement for a child referred with suspected autism could result in one organisation 3 or more sequential referrals or overlapping referrals to different teams. In a different organisation and a neighbouring trust, the exact same child might only get a referral to neurodevelopmental or autism assessment team, just one referral, and actually all of the different bits will be picked up as part of the same referral record. And then again, in the neighbouring area, a child with suspected autism might not even get onto the data set themselves, because autism diagnosis is done by community paediatrics and is therefore in the community services data set, not the mental health services data set.
Yeah, it's a tricky one, isn't it?
Yes.
So I suppose this also responds to one of the questions about the diagnosis data set on why there are multiple diagnoses recorded for the same referral. And
yeah, that's not, we normally get the complaint as why there's not any diagnosis recorded for a person. That's a different issue. So yeah, is that about multiple diagnosis records for referral or
Yeah.
multiple different diagnoses? I guess again, yeah, there's a bit of ambiguity with how particularly primary or any diagnosis is recorded in the data set. The user guidance, I think, encourages services to submit a diagnosis as soon as it's available for open referrals. So from that, what we find is that the primary and secondary diagnosis tables are structured in a similar way to something like the referral table. So again, if someone's referred in January and they're discharged in April, you get 4 referral records submitted to the referral table. If someone has a diagnosis made of schizophrenia in January and they still have that diagnosis when they're discharged, you will have 4 F20 diagnosis records submitted to that primary diagnosis table, resulting in multiple primary diagnosis records per referral ID. In addition to that, you can also have people with the same diagnosis essentially recorded in 2 different ways. This is more of a niche data quality thing, but someone might have their diagnosis recorded both as an ICD-10 code and as a SNOMED code, essentially mapping to the same thing. Or they might have 2 virtually identical ICD-10 diagnoses, but submitted to different levels of precision. This happens to some trusts depending on their clinical system. So with schizophrenia, you might have F20, or they might have F.20 or F2X or something like that, all submitted at the same time for the same referral ID in the same month. And then finally as well, people can and do have 2 simultaneous primary diagnoses recorded at the same time for the same person. And that's where the provider has made a decision locally that there are 2 main reasons that that person is being treated for, and they don't want to put one of them as a secondary diagnosis and one as the primary diagnosis. They'll just put them both as primary diagnoses. So a person has 2 diagnoses at the same time, even in the same month.
Yeah.
Get a lot of questions about diagnosis. So yeah, it's understandable.
Yeah, it's the mindset, the wraparound, right? It's not treating it like a like HES, but
it's not like HES. I mean, I could summarize everything with it's not like HES, sadly.
Yeah.
That's the answer to most of it. You have to do a lot more work, sadly, to get anything useful.
So there's another question, mostly about counting active patients or individuals per year. So I think the question is about, I'll just read it out verbatim. How can I correctly count unique individuals active in services per year using their unique IDs when some have multiple records and some record end dates are missing? So I plan to count a person as active if any part of their record overlaps the year.
Okay. So for that, we publish a measure each month called, I think the ID is MHS01, and it's something like people in contact with mental health services. It's very, very simple definition. It's just a count of unique or distinct unique person identifiers for any person who has a referral record submitted in the year. As I said at the start, a referral record submitted being in the year just means that the referral was open at that time. And I think we have an initial criteria, which is that the service discharge date of the most recently submitted referral record is either null or it's after the end of the reporting period. One word of caution so we publish that measure, and it's like the #1 metric that we do produce each month. One word of caution is to think carefully about what that actually means. It's a count of all people who have some kind of referral in the mental health services data set that hasn't been shut yet. They may have been referred, they might be waiting. They might be waiting 2 years. They might be on a waiting list and maybe never go into treatment and do something like that. So they might not actually be accessing services by any definition at all. The scope of the MHSTS is very, very broad. So it includes basically all wholly or partially NHS funded secondary mental health care and learning disabilities and some autism and ADHD activity, including inpatients, community, lots of crisis stuff. It's very, very broad, basically. And so, yeah, so you can use a measure of how many people are in the data set, which is a huge data set each year. But that might be very different to how we define access in something like a CMHT or a community perinatal service or a CAMS team, which all have slightly different definitions of, is this person accessing the service? We also could look, for example, lots of crisis activity, 24/7 crisis lines and things like that. So someone could have phoned a crisis line once in the year and not got a call back, and then they would be counted.
Thanks, Tom. So there's another question in the comments about, well, I'm interested in what you said about the end of financial year. Is there a meeting targets rush, not only in terms of spring cleaning records, but in terms of making an effort to resolve open referrals through deciding on a treatment / outcome for a patient?
Yes, to some extent. There used to be, nationally at least, a lot more focus on in financial year activity, where we'd monitor something lightly throughout the year and then come down really hard at the end of the financial year, and that did lead to some odd behaviour. That was often focused more on specific service areas, so like children's mental health or community mental health, pregnant access. National, I don't think we have as many big financial year targets now, but commissioners a lot. So we in the sort of the national NHS England policy team are only one, actually quite small user of the mental health service data set. The largest users are our local ICBs and commissioners, who probably will be doing things on a financial year basis, and therefore when it comes to like contract renegotiations at the end of the year and those local commissioning decisions, there'll be a lot more focus towards the end of the financial year to make sure that you are getting all of the activity that service was contracted to provide. So I would say it's perhaps less about performance targets, but certainly about the commissioning kind of cycle.
And can I add a follow-up question to that? And has this performance been consistent, or at least since 2016? Or would, for example, I'm aware that due to COVID, there's been a slightly different capability for services to retrospectively report data to MHSDS, and whether that has caused a problem or different patterning.
I've actually forgotten a massive thing which I wasn't sure if it would come up, which is the ability to resubmit data. And I hope I wouldn't have to go into this, but as I said at the start, organisations submit each month data from the latest month. So I've just today got data for June 2025, including all the referrals open in that month and all the activity. But within each month, organisations reach submission period, an NHS organisation or non-NHS, any organisation has the ability to go back and resubmit historic data within the current financial year. So in the latest cut of data today, I've got, it's going to be published tomorrow, I've got June 2025 data, but then I've also got, for some providers, I've got June 25 data and I've got their May data, and then some providers I've got their June and their May and their April data, but what they can't submit now is any data for March 2025. So the amount of data that we get throughout the year and the ability to resubmit data increases throughout the financial year, and then once we get to just after the end of a financial year, it's cut off and it's fixed, and the data cannot be updated. There's been, to my knowledge, one exception to that, which is about 3 years ago when there was a cyber incident, but like that, where lots and lots of providers, quite large providers, using a particular system supplier, lost a lot of their data, which took them a while to recover it. Some of that data perhaps hasn't been recovered at all yet, and so the submission window was open. That was a very kind of unusual one-off incident.
Good, thank you, Tom. Another comment. Are there any good examples of published information on the use of mental health service dataset and community service dataset together, for example, to look at activity relating to autism spectrum disorder assessment?
Yeah, I don't know, good examples, or any examples actually. There is, I think my team just focused on the MHSDS part. We're quite siloed in that sense. I might have to go away and chat more to the autism program, the autism side, who do those statistics. But yeah.
Yep. A quick follow-up on the snapshot problem of reporting. Does that mean more contacts that happen in March get missed because if they missed the cutoff, they can't resubmit retrospectively?
Yes, potentially. It's been a long time. So before this multiple submission window model was introduced, we just had a primary and a refresh submission period, just two cuts, and it was equal. They still do get two opportunities to submit March data. So what they don't get is the extra up to 10 additional opportunities to resubmit that data. So, and when this new multiple submission window model was implemented about 4 years ago, there was some internal work done trying to quantify how much activity are we possibly missing. And yeah, there was some, but ultimately the benefits of including resubmissions throughout the financial year outweighed the the disadvantages.
Thanks. So the next, well, just to say that we've gone through our most questions on our list. So now if people have questions, please put them in the chat or raise your hand if you want to ask questions yourself. But the next up is a question about the referral to treatment data. So I'm aware that the referral treatment data has a small sample size compared to referral and care contact. If we are only interested in finding out who belongs to the treated group at an attended service, would care contact be an appropriate subset to start with on checking attendance, for example?
Is this referring to the RTT table, the dedicated part of the data set in the MHSDS? There's a whole separate part of it, basically called something like referral to treatment periods. My advice would be to ignore that. It's not. It's a vestigial bit of the data set, which technically I think only applies to allied health professional, a very particular RTT standard that it predates me, and we never ever use it to monitor waiting times. The sad truth is it's not HES, it's not SAS, it's not even the IAP data set where measuring waiting times and everything's very easy because all the derivation's there for you. When we want to measure waiting times, we have, well, I'd say in the MHSTS, many different pathways, each with their own definitions of what counts as entering treatment and their own expectations about how those waiting times are measured. So when you want to measure RTT in mental health services, you have to first think what types of services are we looking, because the definition of the clock stop that we would use, it varies a lot. So perinatal services and maternal mental health services and crisis care teams, we look at first face-to-face contact. With CMHTs, we might use the second attended contact, including telephone contacts. For children and CAM services, we'd say one contact is sufficient, and actually it might include indirect activity, whether signposting or other things. But yeah, basically to get the RTT table in the dataset, I don't think many providers are even submitting to that, and if they are, we don't look at it, we don't validate it. You'd have to go through and use the full referrals, combine that with the care contact tables together to get, this is the referral, this is the date when the referral came in, and here is the first or second of this type of contact to get when they enter treatment. But even then, it's only ever going to be a proxy, because determining like what meaningful treatment is in MHSTS requires a lot of data that we don't necessarily have. So it's a very difficult thing to answer, but I'm happy to,
Yeah, and the service behavior is not constant over time as well. So in terms of waitlist, but Miriam, go for it.
Thanks, Joe. Thanks, Thomas, for answering the question. So if we are only interested in who actually attended the service, should we just use care contact instead of looking at the referral? Because referral is such a massive subset, but they don't necessarily have a follow-up treatment.
So yeah, all care contacts will be linked to a referral, because everything, bar one table or two, links back to referrals. Use care contacts because that's the appointments that actually took place, and also specified using the attendance, what's it called, attend status, used to call it attend or DNA status, where the code is either 5 or 6, which means that they arrived on time, were seen, or they arrived late and weren't seen. And you can also pick the consultation mechanism there, code 1, face-to-face, code 2, telephone, code 4. I've memorized so many of the codes in the data set, I won't do it. But anyway, using that table would show you the contacts, or the care contacts or appointments that took place.
Great, thanks.
Good. I don't think there are questions in line, so just hoping to open it up. Is there anyone else want to ask anything? Oh, Miriam.
Thanks, Joe, again. I would like to ask the follow-up question, because when I look at the care contact table, it has a variable called clinical count, duration of care count. And I look at this variable in together with the attendance status. So some of the attendance was coded as 0, which means that the patient didn't come to the appointment, but the clinical contact duration was still positive, which means that doesn't mean they were designated with a, for example, 1 hour of appointment, but they didn't make it.
Yeah, it would include planned contact as well as actual attended and non-attended. So when that data is extracted from the local system, they'll assign people a slot. You got a 15-minute, assessment, brief appointment here, or 1 hour session of psychological therapies. They'll put that on the system, which is the anticipated start and end time of the care contact, and they calculate that duration automatically. If the person doesn't show up, then yeah, it won't count.
Thank you.
Kate?
Hi, I just wondered if you could talk a bit about using the data over time, because as far as I think we can see, there's more submitters, many more submitters over time. I think when we've talked about it before, just between us, it seems that it's the NHS Trust that we can are more reliably reported. I wonder, is there anything on time trends, or if we were looking at data over time that you could talk about?
Yeah, not much that we've put out officially, but you will see that the number of submitters has increased quite a lot over time. We now get something like 400 organisations submitting to the MHSTS, up considerably from where we were in 2016 or 2017. The bulk of those new, so therefore, if you're looking at time series, you're looking at a time series trend of the number of people referred to mental health services is going to be going up over time. That probably to some degree reflects submitters, new organisations coming online and beginning to submit to the data set, or growth in improvement in data quality, as well as the establishment of new service lines. For example, certain types of services and teams which didn't exist, particularly like prior to COVID or something, start to submit. One thing I'd flag is, of those, dare say there's 400 organisations, there's only really about 60 odd big NHS trusts, which account for like 85% or more probably of all of the activity, with the exception of a few mergers. So Barnet, Enfield, Haringey, Camden, Islington recently merged to form a new trust. They've stayed pretty. The mental health, learning disability, and some of the community NHS trusts have stayed the same. That growth in activity is from tiny, often quite small, voluntary and independent sector providers. But the amount that the growth in independent sector submissions to the data set affects your overall time series depends on what you're looking at. If you're looking at inpatient services, not going to have any of a difference at all, really. There's only a handful of independent sector inpatient services. If you're looking at secure people admitted to secure settings or detained under the Mental Health Act, not going to have a huge impact. If you're looking at children and young people's mental health care, then definitely that might the growth over time in independent sector providers or non-NHS organisations might be much larger, because they comprise a proportionally much larger bit of the CAMS system.
And is that's simply because they're more likely to submit, as opposed to there are more of them?
There are always more. There's probably been like 2 independent sector organisations created whilst we've been speaking, and another 2 have become insolvent and shut down. It's very hard to keep track.
Yeah.
There will be, so there are more being set up. I would say there are 2 kind of forces that get them into the data set. One is if they're providing care that's even partially commissioned by the NHS and funded by the NHS, then as per their contractual agreements, they have to submit their activity to MHSTS. And so therefore, there's people chasing them to do that and get that data online, because they're required to do that. There's also pressure, particularly from regions and commissioners. So children's mental health is a good example. The number one performance measure for that area has been access over the years. How many children are accessing services? Commissioners and regions and systems, the NHS, are being hounded from the national team constantly to improve access and meet access targets over time. That means there's been a lot of pressure, particularly from regions and systems and ICBs, to go out and get all of their local VCSC kind of peer support children's services online, submitting to the MHSTS, so that activity could be counted and contribute towards their regional access totals. And in addition to that, there has been some growth in new services being set up to fill niches that the NHS doesn't provide.
So I'm aware that we are 5 minutes off to finish, so it will be several rapid fire answers to the list of questions.
Try.
So one of them are more related to what we're discussing about private services. So I believe that correspond to private services that are partially funded through the NHS. So how would they show up in MHSDS?
What, the non-NHS or independent sector providers? So they're just submitted just like any other organisation. You usually spot them by the provider ODS code. As a rule of thumb, if it begins with an R or a T, it's an NHS organisation. Anything else, it's non-NHS or independent sector.
Great. Quick question on, in cases where recorded end date is missing, can unique month ID to be used to estimate the end date as a proxy?
Oh, blimey. So is that in the record end date is missing? Ooh. Yes, I would use the unique month ID to estimate the end date if that's what I do. In fact, the version of the MHS I use doesn't even have a record end date. So I derived my own from the unique month ID. There's a lookup somewhere. I can't think of one about month 1502 or 1503 now. But we use that.
Yeah, there's a quick comment on auxiliary information, but I'm not too sure what the question is. Is Simona online? Oh yeah, you're here. Would you like to talk about that?
Yeah, I can clarify that. It's just basically about reliability of it, and do you think any of it is reliable? What sources of it are most reliable, kind of thing? Because it seems a bit inconsistent across tables. Don't know if that's the different sources, kind of inconsistency of where that's coming from, but.
Generally, the key demographic information relating to protected characteristics is okay. It's better. There's been a huge effort to improve and to record and improve that. There is an externally published data quality dashboard which shows the completion of valid and null and invalid records against things like gender and ethnicity. With gender, there is a bit of ongoing challenge. So a few years ago, there was a gender identity code, which is updated to replace the old gender status, and then also another flag for gender same at birth code. These are newer parts of the data set, and the reliability and completion of these fields, which do get a lot of scrutiny, which you can understand, is not as good as perhaps other parts of the data set. The accuracy of something like ethnicity, which is very well recorded, also, MHS is a live data set. You'll often see someone's ethnicity code change because it's self-reported over time. That's just how it works. There is also within the data set lots of so things like disability status is another one that's recorded. That's generally okay because it's fairly straightforward. There is something called social personal circumstances, I think, which is a big, long, messy table added in October 2021 for version 5, which records SNOMED codes relating to things like religion and sexual orientation. That data is not good. Don't use it. It's very poor. And there's all kinds of reasons why I think why we don't record, or we don't, why sexual orientation isn't well recorded in mental health services.
I see Hui-Ping has a comment on clinical services. But again, I'm not too entirely sure what the question is pointing to. Would you like to talk about that?
Oh, thank you. Just our trust recently are working on all the data, and we found all the data is linked to referral. However, in clinical viewpoints, it could be based on individual patients.
Yeah.
So they won't carry out the same measurement or interventions on the same patient, even if it's carried out by their team. But since all this is based on referral and based on the team, so it could affect the audit performance for the team.
So originally, when the MHSDS was first created and its predecessors in the MHLDS and MHMDS, it was originally intended to be not just a commissioning data set, secondary uses data set, but also an EPR itself, in which clinicians would enter data directly onto the data set. But that obviously didn't happen. So there was a huge difference between the MHSDS, as we use for secondary research and analysis, and EPR systems locally, and they don't match. So there are lots of reasons why the clinical systems that are used on the ground will often not reflect there's a lot of processing and a lot of mapping that has to be done very manually to turn the raw data used by clinical systems, which is often at a person level or at a pathway, concepts which aren't really compatible with the MHSDS. And there's a lot of process to turn that data that's used clinically into to fit it to the MHSTS data model and submit it. Basically, it's a long way of saying yes. It's a lot. There's often a lot of stuff gets lost in translation when you're going from local systems to the data set.
Thank
Good.
you.
No, thank you everybody, and especially to Tom for your time and expertise they're so willingly sharing with every one of us. But that's all time we have for today, and we'll upload the recording for everybody to access on the ITALO webpage. And well, I'm sure Tom would be happy to answer some other questions if you do have them still burning in your chest. But that's everything. So thank everyone. We'll see you around.
Great, thanks.
Thanks, Joe. Thanks, Thomas.
Thank you.